everyone. Welcome to today's session titled Current and Emergent Treatment Strategies in Multiple Myeloma. This slide provides faculty information. Myself, Dr. Yuchen Liu, and Dr. Sagar Lonia will serve as your faculty for today's presentation. You can find faculty disclosures on the slide. This program is provided by HMP Education and HMP Global Company, supported by an educational grant from Janssen Biotech, administered by Janssen Scientific Affairs. Learning objectives for today's session include describe factors that influence treatment selection and therapeutic sequencing in multiple myeloma, assess the role of newer and emerging therapies in the management of multiple myeloma, including treatment options for first-line and relapse refractory disease, implement personalized care strategies for the management of patients with multiple myeloma that consider adverse events, treatment-resistant, and alternative administration methods. Apply evidence-based, guideline-directed, and cost-effective managed care strategies to reduce the burden of multiple myeloma. So multiple myeloma is the 14th most common neoplasm in the US, accounting for 1.8% of cancer diagnosis. Although this percentage doesn't seem much, this equates to an estimated 32,000 cases diagnosed in 2020. Since 1990, incidence of multiple myeloma has risen by about 40% in the US, 126% globally. Mortality has increased by about 94% globally, but decreased by 18% in the US. And the 5-year survival in the US has more than doubled over the past decades with the introduction of new targeted therapies and transplant techniques. When we look at multiple myeloma, there are some risk factors, including age, race, sex, and family history. Multiple myeloma is more predominant in the Medicare population with an average age at diagnosis at 69. African Americans are over double as likely to get diagnosed, and men are at about 1.5 times risk compared to women. Despite vast strides in our treatments, mortality rate of multiple myeloma remain high. However, we are starting to see perhaps a turn for the better. In 2020, multiple myeloma accounted for about 2.1% of all cancer deaths. While incidence has risen over the past decade, mortality has fallen due to the drastic increase in survival given the advancements in our medical technology. According to SEER, overall mortality rate for all ages dropped from 3.3 per 100,000 in 2013 to 3.2 per 100,000 in 2017. Among patients greater than 65, mortality rate dropped from 21.7 per 100,000 to 20.5 per 100,000. Even though those numbers seem municipal at this point, it is considered vast improvement in terms of cancer mortality rates for a disease such as multiple myeloma that is very difficult to treat. Cost burden for multiple myeloma can vary based on line of therapy. Based on a study published in 2018, total average follow-up costs from all causes were approximately $288,000. Direct medical costs or direct disease-related costs for all lines of therapy accounts for about 88% of that. Pharmacy drugs, which are the orals, anything that can administer by the patient themselves, 33% of that. Hospital inpatient visits, 30%, and the rest are hospital outpatient, including outpatient administered drugs, which are IV, intramuscular injections, anything that has to be administered by a healthcare professional, those fall under the hospital outpatient drug bucket, and that's about 26% there. Disease-related costs per member per month for the total follow-up period was about $14,000 per member per month, and this is pretty high for cancer. And listed on here also are costs that varies by the different line of therapy. And as you can see, the overall trend is that as the line of therapy increases, so as the patient progresses to become more severe, there is higher cost associated with treating that specific patient. This is another study that was published in 2019. And this is disease-related costs for newly diagnosed multiple myeloma patients, again, by line of therapy. And as you see here, the trend is similar, with pharmacy cost being the highest in that blue bar, hospital outpatient cost in the purple. And then again, some of this due to the new treatment falling under the medical benefit, which you see kind of in that fourth line setting, so the salvage space, where you see a drastic increase in the purple, decrease in the blue. And that's because the newer therapies have targeted at that time the medical hospital outpatient space. So the medical drugs kind of push that salvage cost up for the medical drugs, and then the pharmacy drugs coming down. Again, here shows the comparison between all cost costs and disease-related costs. A good chunk of that comes from pharmacy and hospital outpatient, can be attributed to management of comorbidities, including management of potential side effects from the treatment, such as neuropathy, infection, as well as anemia. More recently, cost analysis started looking at the cost differences based on progression, comparing the different timeframes, because we now have enough data to do large timeframe comparisons. So for this study, published in 2021, annual healthcare resource utilization and costs in the first 3 lines of therapies were compared for patients with or without progression. Now, we understand that on previous studies, the cost of treatment typically will increase as the disease advances, as I mentioned. So here I want you to focus on the 2 different time frame comparisons as opposed to the individual numbers. So between 2006 and 2012, that's period 1. And then between 2013 and 2018, that's period 2. You see that the cost for the various lines, so line 1, line 2, line 3, overall, there is a drastic increase in terms of therapy costs for all 3 of the lines. The period number 2 going up to 100,000, 102,000 for line 2 and line 3 respectively, where it was 70 and 30,000. And again, a significant jump there due to treatment cost increase over the years. Lastly, when we look at the cost burden for the various phases of disease, and this is based on a study published in JAMA in 2021, we see now initial phase and terminal phase cost more than pre-diagnosis and continuing care phase. Again, more related to that, the fact that the newer therapies and then treatment selections for the initial phase and the terminal phase being a little bit more expensive given newer options in those phases. Especially in the salvage phase these days, we are starting to see a lot more innovative therapies, again, coming with a heavy price tag, which we'll talk about later on how to manage those therapies. I will now transition to Dr. Lonio to discuss how to select the right treatment for patients with multiple myeloma.
Thank you very much, Dr. Liu. I'm Dr. Sagar Lonial, Chair and Professor in the Department of Hematology and Medical Oncology from the Winship Cancer Institute of Emory University in Atlanta, Georgia. And I'm going to continue to talk a little bit more about relapsed and refractory myeloma, choosing the right treatments for patients in their journey. So I want to start off really talking about the current state of what we should expect for an outcome for patients in first remission. And this is an analysis of 1,000 consecutively treated patients at our center called the RVD 1000 series. And what we demonstrated was that the median PFS for all patients was about 65 months. Median overall survival for all patients was over 10 years. But more importantly, if you begin to look at the standard risk in red, what you'll see is that their median PFS is almost 80 months, 80, and their median overall survival has not been reached now with 14-year follow-up. And what this suggests to me is that you need to be really aggressive. You need to maintain induction, consolidation, and maintenance therapy for a long period of time in order to maximize the duration of that first remission. Now, unfortunately, despite our best efforts to do so, many patients with myeloma will ultimately relapse of their disease. And as we need to do with pretty much all other areas in oncology, what we also want to do is begin to think through disease and patient factors that may influence outcomes in the management of relapsed and refractory myeloma. And these include things such as frailty, disease comorbidities, risk assessment, treatment history, and lifestyle. And at the end of the day, you take all of these orange boxes, put them into context with the gray boxes, and ultimately come up within the blue box of the optimal treatment for that given patient that is effective, safe, and ultimately maintains quality of life. And these are just some simple characteristics that I think through when I'm seeing a patient with early relapsed myeloma. Now, historically, we've thought about backbones in myeloma, and we think about proteasome inhibitor backbones, whether it's bortezomib or carfilzomib. We think about IMiD backbones, whether it's lenalidomide or pomalidomide. But more recently, we've been focusing on CD38 backbones, and those currently include both daratumumab and isatuximab. And when I think about how to manage a patient in early relapse, typically I'm going to start with the anti-CD38 and either pair it with an IMiD or with a proteasome inhibitor. That's sort of the mindset that I bring to the table when I begin to think about patients with early relapse. And we know that there are a number of studies looking at lenalidomide and dexamethasone as partners versus lenalidomide and dexamethasone. And you can see many of these trials here evaluating ICSA, ELO, carfilzomib, or daratumumab in partnership with Lendex versus lenalidomide and dexamethasone. And while these hazard ratios certainly do look quite impressive, the reality is what I have written up here underneath the main title of the slide, which is this really relevant for modern myeloma practice? And the reason I say that is that we know that most patients in 2023 are progressing on lenalidomide maintenance. And so the benefit of a len control arm or a len combo is really pretty marginal. And I don't really think about any of these in that context because every patient that I take care of is progressing on lenalidomide maintenance. We then start to look at bortezomib and dexamethasone as the control arm. And what you see on the top are a number of clinical trials, including pomalidomide, daratumumab, carfilzomib, selinexor, or venetoclax, partnered with a proteasome inhibitor or against a proteasome inhibitor head-to-head. And what you see, again, is fairly impressive data in terms of hazard ratios, probably more so for the daratumumab bortezomib dex versus bortezomib dex arm here. And that certainly has become a major primary go-to for patients or for groups that want to use a PI as a backbone when you're thinking about these patients. Now, more recently, we've seen a series of pomalidomide-based salvage therapies for patients with relapsed and refractory myeloma. These include the combination of PD alone in refractory myeloma, KPD, DPD, IPD, EPD, and ISA pomalidomide and dexamethasone. And we're going to go through some of these in a little bit more detail. But what I want you to take away from this is the idea that, to me, again, you're going to take a CD38 antibody in early relapse and partner it either with a proteasome inhibitor, either bortezomib or carfilzomib, or with an IMiD. And the IMiD in most of these contexts is pomalidomide because they are lenalidomide resistant. So let's talk about a number of trials, again, that look at daratumumab with partners and partners that are actually relevant in the modern era. So let's skip this first column here and really focus on dara with carfilzomib and dex versus cardex, or dara with pomalidomide and dex versus pomalidomide and dex. And I think it's important to recognize that, these two trials are actually not the same. The dara-cardex or CANDOR trial in the middle column had much fewer lines of therapy on average than we saw in the Apollo trial, which is the third column on the right here. And so I think what you may be seeing when you look at differences in progression-free survival really relates to differences in patient populations, not necessarily differences in efficacy of these regimens. And the reason I say that is there are patients in early relapse who can have very long remissions, particularly with dara-pom-dex. Those are patients who tend not to have high-risk disease at the time of relapse or do not fall into the functional high-risk group. And we'll talk about this a little bit later. On the flip side, we can look at similar combinations in the second and third column, looking at isatuximab plus carfilzomib and dex, or isatuximab plus pomalidomide and dexamethasone. And what I think this, again, really does is demonstrate very similar PFS and OS curves, whether you use ISA or daratumumab as the proteasome or as the CD38 antibody, and partner it with either carfilzomib, the PI, or pomalidomide, the IMiD. And again, what you're seeing is similar in that most patients who got the carfilzomib combination were earlier relapse compared to patients who got the pomalidomide combination, which is a later relapse, simply by definition of the FDA label. So here is data from our own center evaluating dara-pom-dex in first relapse. And what you'll see in cohort 1 was patients who were sensitive to both POM and DARA. And again, what I think you're looking at is really nice progression-free survival, somewhere in the magnitude of about 40 to 45 months here. Again, this was a very small series that we published a number of years ago. And again, if you look at Apollo, you're seeing a slightly different analysis here. This shows that the median PFS is closer to a year. And the reason it, again, is closer to a year is these are on average 2 to 3 prior lines of therapy, not 1 prior line of therapy, which is what we're seeing in the analysis I showed you before. But nonetheless, clearly the triplet is better than the doublet in this context. At the same time, you can look at DARA in partnership with carfilzomib. Big difference in progression-free survival, favoring the triplet of DARA, CAR, Dex compared to carfilzomib and dexamethasone alone. And again, look at the shapes of these curves, and when they begin to separate, you're going to see very similar differences when you use isatuximab as well. Now, here's ISA-POM-DEX versus POM-DEX. Again, median PFS is very similar to what I showed you for Apollo. The same caveat, later lines of therapy, so you're not getting the maximal benefit from pomalidomide by giving it later in the disease course, and that accounts for why it's 11 months versus longer, in my view, with carfilzomib. But certainly these are debatable questions. But again, what you're seeing is equivalent improvement with the addition of a triplet over a doublet. And again, when you look at the isatuximab combination with carfilzomib, you're seeing something very similar here to what I showed you for Icaria before, or for Candor before, which is PFS curves that do separate relatively earlier. And the shapes of these curves look similar for isatuximab CARDEX versus DARA CARDEX as well. So again, these two really do demonstrate, to me, the PI that I'm going to go to is going to be carfilzomib, and I'm going to partner it with the CD38 antibody, or the IMiD would be pomalidomide, and I'm also going to partner that with the CD38 antibody as well. Now, in later relapse, you may think about things like ELO-POM-DEX. This is the ELOQUENT 3 trial that randomized patients to EPD versus PD. If you used CAR-DARA-DEX as your first relapse, this would be a reasonable opportunity or thing to consider in second relapse. ELO-POM-DEX, where you get synergy between the SLAM-F7 monoclonal antibody in partnership with pomalidomide. And again, the patient is not POM resistant and they're not ELO resistant. So this does represent a reasonable next step for many of those patients as well. Now, one of the things that I wanted to touch on is the way that our group makes a decision on what to do in first relapse. And what you'll see on the right here is progression-free survival based on how long that first remission is. If that first remission was more than 30 months, then the PFS for dara-pom-dex can be quite long, has not been reached yet with 40-month follow-up, whereas if that PFS from diagnosis was less than 30 months, then dara-pom-dex doesn't necessarily represent a good option. And in those patients, we will treat with dara-CARDEX at our center versus dara-pom-dex for patients who fit into the green curve version of this graphic. Now, another potential option to use in the context of relapse disease is selinexor. This is the STORM trial in penta-refractory patients that use selinexor on a twice-a-week dose and schedule. And what you'll see here is an overall response rate of about 26%. Median duration of response was about 4 months. Median PFS was about 3.7 months. And this led to the FDA approval of selinexor in this context. However, in another randomized phase 3 trial, they tested selinexor plus bortezomib dex versus bortezomib dex in an earlier relapse patient population, 1 to 3 prior lines of therapy. And what you're seeing is a significant improvement in progression-free survival, 13.9 months versus 9.4 months here, favoring the group that got selinexor. And this to me is yet another example of a triplet being superior to a doublet in the context of relapsed multiple myeloma. Now, I want to get into what I think is ultimately the best example of precision medicine in myeloma, and that is targeting patients with the 11-14 translocation. And what I think you'll see here is that when you use venetoclax, specifically in the 11-14 patient population, as a single agent, you're getting a response rate of about 40%. When you add dexamethasone in the phase 1 portion, we had a response rate of about 60%. In the phase 2 portion, we had a response rate of about 50%, somewhere in this ballpark here. And this data to me does in fact really represent precision medicine and an opportunity to move forward with venetoclax in a very small patient population, the 11-14 subset. Unfortunately, when it was tested in a phase 3 trial, it was tested in all comers. And the Bellini trial is a trial that you may have heard about that likely did in many ways more harm than it did good, because it took venetoclax, bortezomib, dex versus bortezomib and dex in all patients with multiple myeloma. And this study really demonstrated a significant improvement in progression-free survival, but a decrement in overall survival for the patients who got venetoclax. And I think it's important to understand why this was the case. This was really the case in the non-11-14 patients, where I would argue they don't get benefit from venetoclax. If you look specifically here at the 11-14 subset, what you see is a big difference in progression-free survival and no reduction in overall survival, and in fact, trends towards improvement in overall survival for the 11-14 subset who got venetoclax. This is the group where I only think about using venetoclax. On the other hand, if you begin to look at the 11-14 negative, you see the exact opposite, that they didn't get much of a benefit from progression-free survival, and they certainly did not get a benefit in terms of overall survival. And this, to me, really represents the weakness of this trial. There are a number of trials now looking at venetoclax specifically in an 11-14 subset of patients and using that to ultimately drive the biomarker-driven use of venetoclax-based combinations in multiple myeloma. Now, I want to switch gears a little bit and talk about BCMA in multiple myeloma, because BCMA is an area where I think we are all very excited about using new agents and new drugs because we have multiple targets. We have had and don't have now, but hopefully we'll have again, antibody drug conjugates, such as belantamab mafodotin. We have bispecific antibodies like teclistamab. We have CAR T cells like cilta-cel and ide-cel. And this is really important because BCMA is an important target in the context of multiple myeloma. And more specifically, BCMA plays an important survival role in long-lived plasma cells. So interrupting BCMA signaling in the context of a survival of a malignant cell may in and of itself be important, but it also serves as a way to bring in immune effector cells to ultimately kill malignant plasma cells as well. So let's talk about the phase 2 KARMA study of ide-cel. This was a phase 2 study that used BB2121, that used a standard CAR T-cell approach with a dose escalation of ide-cel. Again, you'll see all patients got Flu/Cy as their lymphodepletion. About 140 patients were evaluated in leukapheresis, and over 100 patients ultimately ended up receiving their product. If you look at response rate, you can see the highest response rate was with the highest dose. If you look at progression-free survival by target dose, you'll see the PFS is somewhere around a year for the median, depending upon which dose was used in this context. And I think what this really represented was a significant step forward and the first CAR T-cell we had in the context of multiple myeloma. We then had a second CAR T-cell targeting BCMA. This was cilta-cel, as evidenced by the CARTITUDE-1 clinical trial. Cilta-cel is different structurally than ide-cel in that it binds BCMA in 2 different locations. This may give it some unique attributes that allow it perhaps to be more effective and perhaps not be as dependent on persistence to ultimately, we hope, cure patients with multiple myeloma. And as you saw in the CARTITUDE-1 study, overall response rate of 97.9%. PFS by response rate and MRD is really very impressive. with the median PFS not reached now at 30-month follow-up. And more importantly, overall survival for responders really quite impressive as well. And so what I think this really does is, again, set the stage and establish that CAR T cells are a very reasonable treatment for patients with refractory myeloma. I think the real question comes down to, is there a plateau on these curves that ultimately leads to a cure, like we see in the context of CD19 CAR T cells in diffuse large B-cell lymphoma and ALL? Now, what about CRS and ICANS? CRS and ICANS do occur with both cilta-cel and ide-cel. What I like to think about is that BCMA-directed CAR T cells have on average 1 grade less severe CRS and ICANS compared with CD19 CAR T cells. What you'll see here is only 17 patients, or 2% had grade 3, grade 4 versus 3% grade 3, grade 4 with ide-cel. Infections we're going to talk about later because that is common not just to CAR T cells, but also bispecifics. And again, we do see some level of cytopenias, including neutropenia and thrombocytopenia, some of which may be related to the Flu/Cy lymphodepletion, some of which might also be related to the product and CRS as well. The other new category on the block, if you will, are bispecific T-cell engagers. These are basically monoclonal antibodies that target CD3 on one side and BCMA on the other side, and that creates a bispecific antibody that then brings in close proximity an activated T cell with a tumor cell. And this has the advantage of being off the shelf. It has the advantage, again, with potentially less toxicity than a CAR T cell, but not zero toxicity compared to a CAR T cell. So the Majestic-1 is the trial that ended up leading to the FDA approval of teclistamab. In this context, overall response rate of about 63%. First response occurred 1 month into it, best response about 4 months into it, and there were a significant fraction of patients that achieved MRD negativity as well. More importantly, if you begin to look at progression-free survival, about 11.3 months, and duration of response is much longer, likely closer to 17 to 24 months for the median duration of response among people who achieved deep responses who received teclistamab. Now, the other bispecific antibody that's in development is elranatamab, and these were done through the Magnetism trials. Magnetism MM1 is a trial that used elranatamab in escalating doses in the context of relapsed and refractory myeloma. And what we demonstrated was that elranatamab is, in fact, quite active with an overall response rate of about 64% among 55 patients who received the target dose or higher. When you begin to look at the swimmer lane plots here, what you see very nicely is that many of these patients deepen their response over time. And in fact, many of these responses are ongoing beyond 2 years since their initial treatment. And this, to me, again, very exciting data and suggests that this can be, in fact, a very important and active treatment in the management of patients with refractory multiple myeloma. Now, there are a number of other BCMA-directed bispecific antibodies in development. These include TEC and LRAN, as I described already. There's also the Regeneron compound. There's the Celgene compound of alnuctamab and the ABV3A3 compound. These are all highly active and effective bispecific antibodies. Similar response rates, similar CRS and ICANS rates. What we don't know ultimately is whether any one of these is more or less durable than what we've seen with teclistamab or elranatamab. And ultimately, we need larger patient populations in trials to dissect some of this out overall. If you begin to look at safety, you'll see here, as I mentioned just a moment ago, CRS rates are relatively similar between them. CRS greater than grade 3 is relatively rare. Neurotox is relatively uncommon. And again, grade 3 or grade 4 in terms of neurotox is relatively uncommon. All of them cause some level of hematologic toxicity, and that likely is a consequence of efficacy. When you get CRS or inflammation in the marrow as a consequence of drawing in T cells and activating them, to kill myeloma cells in a heavily packed marrow, you will likely get some form of cytopenias. And so be prepared for this, be ready to manage this in order to minimize its impact on your patients overall. Now, coming down the pike, we're very excited to have additional new potential targets. These include things like GPRC5D, like teclistamab, like talquetamab, or FCRH5, like cevostamab. This is 2 more series of bispecific antibodies that we'll have in myeloma. And at least for GPRC5D, we now have CAR T cells that are coming targeting GPRC5D as well. So a number of emerging targets beyond BCMA that I think will hope and help us to keep our patients moving in the future with many of these new targeted therapies that are really based on immune recognition overall. So in conclusion, I think recognition of previous resistance and toxicity does in fact play a role in choosing salvage therapy. The goals are to get deep responses and maintain those, even in the context of refractory myeloma. The backbone of, to me, in early relapse is an anti-CD38 antibody, and you're going to partner it with either an IMiD or a PI, and then think about personalized medicine in the context of the 11-14 patients, and think about BCMA and other targets emerging that are likely going to move earlier and earlier in the disease course. So thank you very much for your attention. And with that, I will turn things back over to Dr. Liu.
Thank you, Dr. Lonio, for the clinical overview. We will now switch gears a little bit to talk about management considerations. Now, when it comes to payer management for the oncology space, the gold standard is the NCCN guidelines. Payers will often also use the evidence blocks to see if there are any preferences that may be given to certain regimen selections. But outside of that, most payers will endorse the entirety of the NCCN recommendations. Other European guidelines are sometimes used as supporting evidence. For example, when a new therapy that was previously approved in Europe comes out, and then NCCN has not incorporated that specific regimen into its guideline, payers will look at the total evidence and use the European guideline as a reference for coverage. But for the most part, NCCN has been pretty much staying up to date in this space, so NCCN is still considered a gold standard. Now, before I get into the treatment selection process, I want to make sure that we have a good understanding of what goes into a formulary selection process. When a new drug comes to market, first we look at the clinical portfolio for the drug as a whole. And this is typically completed by a managed care pharmacist all the way up through the P&T committee, which is the ultimate body that makes clinical decisions within a managed care organization. The review starts with a full clinical review, which includes a key comparison of available literature, safety, efficacy, guideline recommendation, as I mentioned, the NCCN guidelines, as well as key opinion leader feedback. So oncologists within the network of the payers will gather insights that way to see in clinical practice, how are these new drugs used? How are these new regimens being used? And are there already some kind of natural preferences product-wise as well as regimen-wise? The next step is a financial portfolio review. The cost of the drug, the cost of the entire regimen, the cost of ancillary services such as physician office visits, management of side effects, hospitalization, as well as medical cost offsets are all factors that are taken into consideration during a financial portfolio review. And then when the time comes and we're ready for formulary placement, there are a couple different management tools that can be used. Tiering is a very common one, especially seen on the RX benefit side for any of the oral oncolytics. That is to create a natural shift since patient will be responsible for less of an out-of-pocket difference. And for a specialty product, this difference could be especially significant since the patient may be responsible for up to 20% of a co-insurance or very high copay. So tiering definitely, it's a very important tool on the RX side. Prior authorization is another one. You'll see pretty much all the oncolytic products, especially the newer ones, on PA just to ensure appropriate use, because we have seen throughout the decade a lot of off-label utilization for oncolytic regimens. There are arguments going both ways, but mainly payers will be prior authorizing a lot of these newer oncolytic treatments. We are starting to see some regimen-based prior authorizations for organizations that are capable of doing it, especially in a value-based arrangement. Regimen-based selections are preferred. Step therapy, if there are preferences stepping through a preferred regimen or product prior to others, step therapy is usually coupled with the prior authorization. And specialty pharmacy distribution consideration, this is related to getting access to the drug itself. If you have a narrower distribution channel versus a faster one, it's usually a way for payers to kind of control access there. Now, the formulary process also is applicable to regimen preferencing, as I was mentioning before. And step one is a clinical review of the entire regimen. Putting everything kind of together, NCCN make a lot of those recommendations in their guidelines already. So to give you a real case example of how payers may prefer certain regimens, based on the NCCN evidence block and category recommendations, the NCCN defines the preferred intervention as interventions that are based on superior efficacy, safety, and evidence, and when appropriate, affordability. Other regimens are defined as regimens that may be somewhat less efficacious, more toxic, or based on less mature data, or significantly less affordable than compared to regimens of similar outcomes. And then they are also recommending regimens that are useful in certain circumstances, which are other regimens that may be used for selected patient population, for example, elderly population, more aggressive population. The differences vary a lot there. So with those regimen preferences given by the NCCN, NCCN also assigns categories based on the strength of data. So a category 1 recommendation assigned to a regimen has the highest quality of evidence. So for example, a transplant candidate, bortezomib, lenalidomide, and dexamethasone are assigned a category 1 recommendation. Also under the preferred regimen there, carfilzomib, lenalidomide, and dexamethasone is not a category 1. So you will see some clinical preferences, especially from the payer side, given towards a category 1 preferred regimen. That is not to say that the other regimen is not appropriate, it's just weaker in evidentiary support. And when you consider kind of outcomes and long-term impact and how comfortable the providers are using these products, a regimen with category 1 is definitely more clinically preferred compared to, not a category 1. When the NCCN recommendations are the same. So for example, for the non-transplant candidate there, the primary therapy have both category 1 recommendations for the 2 regimens listed there. You'll sometimes see that payers may select a less costly preference to prefer. It is rare that you'll see that these days. However, for some more aggressive payers, we are starting to see kind of like a pathway built for the multiple myeloma space. Now, when you make these type of decisions, especially as managed care pharmacists, you must take into consideration, as I said, the whole financial portfolio. For example, the product Darzalex Fast Pro, right? Darzalex is the IV, Darzalex Fast Pro is the sub-Q. For products such as Darzalex Fast Pro, it does have the advantage of convenience, also less chair time. So the admin cost for that less chair time needs to be also taken into consideration when you're reviewing this entire regimen. Not a lot of payers have established a step therapy, for Darzalex and Darzalex Fast Pro. And it's exactly because of that, it's the admin time that also needs to be taken into consideration when selecting a regimen. So all of that needs to be taken into consideration when doing product sequencing. Ultimately, the regimen selection needs to be based on patient-specific factor and the patient needs to make sure that the patient can actually stay on the right regimen and get the disease treated. Now, as Dr. Lonio talked about treatment selection, I'm not going to repeat it here, but I'm hoping to convey the message to you that one of the biggest challenges for payers when it comes to multiple myeloma is in this relapse treatment space it's really the wild, wild west out there. There are a lot of different regimens. The sequencing is unclear because when you take a look at the NCCN guidelines, you see pages and pages of different regimens, all with preferred status, category 1 status. There is a lot of data in this space. And therefore, the selection of regimen can be highly customized based on the patient clinical profile. And for payers, we do have some guidance in terms of cost effectiveness through systematic reviews and ICER reports. However, those are currently not as enforced for the space, just due to the variety of different treatment in this space. So we will take a look at a few of these analyses just to give you an idea of what's out there. This first one we'll take a look at. This is a systemic review that was published in 2021. Some of the newer regimens with isaximab and elotuzumab backbone cost around $400,000 to $500,000 per quality compared to the lenalidomide dexamethasone combination, and those are way out there down in the those are the couple ones that are down in the far corner that are very expensive. And here again, here's another analysis that shows regimens with elotuzumab and isaximab backbone with a higher ICER compared to the lenalidomide dexamethasone combination. With newer therapies on the market and more rigorous data, these cost-effective modelings can serve as reference points for potential regimen selections. However, as I said, patient-specific characteristic needs to be taken into consideration as well. So again, you will see, you will not see a lot of payers starting to force these cost-effective modelings on regimen selection, but they are used as sort of the backbone for understanding this therapy in this ever-evolving treatment space. Lately, the new therapies, I want to say in the recent 5 years or so, are focused in this salvage space. After at least 4 prior therapies, including an anti-CD38 monoclonal antibody, API, and IMID new therapies, and these salvage therapies include 2 new CAR-Ts and 2 monoclonal antibodies. Salvage means that they have pretty much exhausted all prior lines of treatments, hence the requirement to give at least all, all have tried at least all 4 of these therapies. Now, one of the monoclonal antibodies have been discontinued in the US market, and that is Blenrep. It is now only accessible through a compassionate use program. After at least 4 prior treatments, disease is refractory, so this is a dead last resort, pretty much salvage therapy. You have selinexor and dexamethasone as an option that is recommended by the NCCN. Now, the cost effectiveness of these CAR-Ts are interesting. They came to market, in theory, we've seen a lot of good results from the CAR-T therapies in other types of cancers. Now, in multiple myeloma, it's still fresh and brand new, and the actual value of these CAR-T therapies have been questioned. So ICER did release an analysis comparing the CAR-Ts as well as Blenrep, but again, Blenrep has been removed from the US market, so the data here will no longer reflect Blenrep. Just looking at ide-cel and cilta-cel here, cilta-cel is more cost-effective in terms of cost per quality gained, cost per life year gained, cost per equal value life year gained, as well as cost per additional progression-free survival month gained. So in other words, ICER have really favored cilta-cel in this report. Now, when we look at the ICER recommendation for pricing, typically cost-effective is defined as anything is for a price that is reasonably priced to achieve a $150,000 per quality. The unit price for ide-cel should be around $245,000. For cilta-cel should be around $292,000. Both products are currently overpriced, with ide-cel priced at $457,000 and cilta-cel priced at $479,000, which is 86% and 64% over the ICER recommended cost-effective price, respectively. Many times when we think about patient care, especially in these types of cancers, such as multiple myeloma, which is going to be a long battle, it's typically being viewed as an oncologist-managed disease, and that should really not be the case. The reality is that we really want our management to be based on the patient, a patient-centric one. So, for example, we need to understand how to improve adherence, especially with the oral oncolytics as a part of these regimens now, whether it's providing direct patient care outcomes, whether it's direct education to the patient as well as the patient caregiver, the more comprehensive review, such as MTM type of services, which are all services that are currently needed and we need to provide to the patient. It's no longer a one direction kind of I feed you the information. It needs to be, we need to get some feedback from the patient on whether or not they want and they understand the treatment as well. So a patient-centered approach can be summarized by 4 interactive elements and their corresponding goals. Number one is exploring health goals, disease, and illnesses experiences. And the point here is to understand each patient's unique perception of health and illness. Does the patient understand what multiple myeloma is? Does he understand what the disease is? Is he prepared to go on this journey, which, as you've seen previously, you have to go through several different lines, and there are a lot of different phases of this disease. How much does the patient understand? The second part is to understand the whole person. The goal here is to integrate the clinical concepts with an understanding of the whole person, the whole patient. What does the patient want to get out of treatment? And thirdly is to find common ground, define the medical problem, establish goal of treatment, and identify the role to be assumed by each of the stakeholders, including the patient, the pharmacist, as well as the provider. So here, after you have a good understanding of the patient, the patient understands the disease, the patient wants to get treated, the patient wants to achieve the best possible outcome. All right, with these ideas in mind, how do I, as a clinician, help the patient achieve this goal? And that's to incorporate knowledge from both sides to be able to get this disease under control. And then lastly, enhancing the patient-centered relationship. And the goal here is really to build on the patient-clinician relationship here with compassion, empathy, and a sharing of power, healing, as well as hope. And I think this is probably the most important part, to show the patient that we care and understand that this is not just a oncologist-driven, not just the oncologist, wanting to push treatment onto the patient, but, us as other healthcare providers, pharmacists, all the different stakeholders. We need to understand that we need the patient to understand that all of us are doing this for the best of the patient. So with the patient-centric model in mind, managed care strategies can include comprehensive management programs such as MTM services, nurse case management, targeted outreach programs, as well as adherence programs. Other management strategies can include pathways, which are treatment selections, as we discussed earlier, potentially sequencing treatment and regimens, as well as a value or risk sharing arrangement to help drive utilization towards the most cost-effective therapies. A lot of those types of arrangement has to come from kind of the provider initiated or payer initiated to make sure that the providers are also being reimbursed appropriately for and receive ultimately rewards for selecting the most valuable therapies for the patient, the most cost-effective one for the patient, and that the treatment that's selected for the patient, the cost-effective, also means that it is not less effective than any of the other regimens that could potentially be offered. And that concludes the program for today. We'll do any questions at the end.
Thank you, everyone, for joining us today. I am Dr. Liu, and I am here with Dr. Lonio to answer your questions. If you have any questions for us, please send them in the chat box. in the meantime, here is the first question that we have. For Dr. Lonio, when is the best time to refer for CAR T therapy?
Well, I think if you look at the current labels for both BCMA-directed CAR Ts, it's really in 4 or more prior therapies. And so from my perspective, getting a referral probably when somebody is starting on third-line therapy is a good time for the CAR T center to see them again, because there's a huge amount of logistics from an insurance perspective that you have to go through. And it just takes time to schedule the apheresis and all of those other issues. So I certainly like to see people at second or third relapse in anticipation so that my team can meet them and get them ready for the collection down the road. Now, that is likely going to change with the 2 randomized phase 3 trials looking at early relapse compared to CAR T-cell. And both of those trials, CARTITUDE-4 and KarMMa-3, demonstrated benefit for early use of CAR T-cells. And so in that context, probably at first relapse would be a time for the patients to be seen at the CAR T center to really consider alternative therapy options.
Great. Thank you for that, Dr. Lonio. The second question we have, also for Dr. Lonio, how do you consider the bispecific versus CAR T therapy in late relapse?
You know, this is the big question, because both of them are available. Both of them have very similar response rates. The efficacy in terms of duration of response may be a little bit different, but certainly they're highly effective therapies. And the things that I like to think about is, how quickly do I need a response? Let's say you wanted to go to a CAR, you're going to have to wait 6 to 8 weeks for manufacturing. No matter what you do, you're going to need an apheresis slot. So it really is the early or indolent relapse that can go immediately to a CAR T cell. On the other hand, the advantage of a CAR is that once you're done, you're not on anything for a period of time. And many patients really like that idea of not being on anything at all. And while the infection risk may be similar between a CAR and a bispecific, it's much shorter in a CAR than it is with a bispecific. Because remember, with a bispecific, they're on continuous therapy, and that continuous therapy makes it a little bit more challenging to go through that process overall. So I think those are factors that we think about, how quickly, how big a response do people need. Those are all factors that go into it.
Gotcha. No, definitely a concern for us payers as well, in terms of how do we preference, or how do we choose between the bispecific versus CAR T for some of our patients as well. Next question that I see that are coming in. Well, genetic therapies have a significant impact on myeloma therapies and cost. I think this one is probably directed at me. So from a payer perspective, we have seen significant ASP drops for products that does have a generic available. For example, Velcade ASP prices dropped about 86% already since 2022. And when we look at the latest ASP file from this quarter, so definitely significant decrease in terms of the overall treatment cost for any regimen that contain a generic component. With that said, you will also see payers starting to prefer some of these less costly regimens upfront, Velcade, Lenalidomide, pomalidomide, all these types of products upfront, and then considering some of the newer emerging therapies, specifically the bispecific and the CAR Ts much later on in terms of line of therapy. Which I think that's a very good tie-in to the next question, which is for Dr. Lonio. For patients progressing on lenalidomide maintenance, is there a role for len-based salvage therapy as well?
Yeah, you know, this is an interesting area, and I think it does sort of speak to two things. The first is progression on low-dose lenalidomide in the context of maintenance the same as bigger dose lenalidomide with or without dexamethasone? And what I know is a couple of things. The first is when the French did the randomized trial of len versus observation as maintenance, a number of patients that progressed on len went on to len-based or len-dex as salvage therapy. And what we learned from that, it's never been published, but what we learned from that was that the median response was less than 3 months. And so when you progress on len, it doesn't matter what the dose is, you're not likely to get long-term benefit from lenalidomide in that context. So as much as it pains me to say this, the CAR Lendex versus Lendex, ELO Lendex versus Lendex, DARA Lendex versus Lendex, all of those trials actually have no relevance in the modern era because most patients are progressing on len maintenance. And so I do not recycle lenalidomide in that context.
Gotcha. And then the last question that just came in looks like it's going to be for me. So when will payers begin to closely manage the multiple myeloma treatment space as higher cost therapies continue to emerge? This is a very tough question here. As we know, for the multiple myeloma space, the management there is just the wild, wild west, is like everything goes. But we have started to see payers starting to dabble into the space with pathways, especially in the salvage therapy space, as Dr. Lonio mentioned before, bispecific versus CAR T is always a question that we're asked. You will start to see some payers who are the frontier of the space. They will start to select and pick preferred regimens for exact reason I mentioned before. Some of these generics are much cheaper in terms of the overall regimen cost. Now, anytime we make those type of decisions, it has to make clinical sense. So NCCN is still the go-to gold standard in terms of regimen preferencing. It's only if the regimens are same from an efficacy perspective and a safety perspective, then we can consider preferencing the regimen with the overall less costly that's the overall less costly option in that space. In terms of the CAR Ts, we have not started to see any kind of step therapy preferring one CAR T over another. Now, in the value-based contract space, you might see that change a little bit for the value conversation that we have in terms of which CAR T therapy may be preferred over another, but that is still way, way early in conversations, and I don't think any payers have solidified on that. So more to come in the space, definitely. I think that's all the time we have today for questions. Again, thank you for joining us. Please remember to claim your CE credit following this session and have a fabulous rest of your day.
Thank you.